Hey, good morning. I'm Bryce Hamilton. I'm on the forum committee. And first question, how many of you wear hearing aids? Wait, look. Wow. How many of you, the few of you remaining, think maybe you should and haven't yet? Okay, be honest about it. That's why our guests are here today, to talk about hearing loss. Anyway, we're delighted to have our beloved long-time Plymouth member Ann Seltz with us, along with her colleague, Sarah Binfet. And Ann is a retired audiologist, most recently employed at the VA Center. Many years of experience in hospital, community, clinics, and in public schools. And Sarah is the owner of SoundGate Hearing Clinics, and like Ann, is passionate about educating and empowering patients on hearing loss and on treatment options. So we're delighted to have them with us. And just to remind you, at this time, at the end, when Q&A comes, just raise your hand and I'll pass along a mic to you so that our people online can join in also. Welcome, Ann. Welcome, Sarah. We're delighted to hear what you have to say.
Good morning.
Good morning.
It's been a long time. Thank you. Just put my water bottle on. So most of you are hearing aid users already, huh? I'm not the expert on hearing aids. Sarah is, but because I've been retired for a while. And I live in a senior housing center, and I would say about 80% of them have trouble hearing. And I would say about 40% have never been treated. So it's always an interesting communication experience to be there. And once they find out I'm an audiologist, they usually ask me 3 questions. This place moves. What do you think they are? What do you think people ask me? Anybody, just guess. How much do they cost? What else? Do they work? What brand? Actually, no one has ever asked me if they work. They might complain that theirs don't, but the first question most people ask me is, what's the best brand? Or what brand are you wearing? And I don't usually tell them what brand I'm wearing, but I usually say, well, that's like asking what's the best brand of cars or refrigerators or whatever. And the really big issue is who you work with to help decide how you're going to manage the communication problems you have because of the way you hear. And in my opinion, it's an audiologist. And just like not all doctors are great, not audiologists are perfect. So you want somebody who is going to listen to you, who's going to, I think you can assume they're knowledgeable about evaluation, assessment techniques, and pretty knowledgeable about technology, but you want someone to listen and find out what are your problems. And that's a very important characteristic. If the first thing they ask you is what's your insurance, I would not go back. I want to warn you all, I took a Tylenol this morning, so if something happens, you'll know that the president was right. Just amazing, isn't it? I'm not going to ask you a question. I'm not going to answer questions about what's the cost of hearing aids. But one of the things I want to talk about, and a question that you didn't raise, but is how do I get someone else to get hearing aids when they don't want to do it? Do any of you have that experience at all? I need to know, otherwise I won't talk about it. Okay. The best advice I have is don't offer a solution to a problem that's not perceived. Do not say, Grandpa or Dad or whoever, you need hearing aids. Because, first of all, it doesn't work, but secondly, they have the best knowledge about themselves than you do. You are not an expert on hearing aids. You're not an expert on how they function. But you are an expert on how you respond to the way they function. And you can say, you know, it makes me so sad when you don't understand your grandkids. Or it just makes me feel a little irritated when you keep asking me to repeat what other people say all the time. That you can talk about, because that you are an expert on. And you can offer to go with them and seek help. But don't tell them they need hearing aids, because if any of you have ever tried, you know it doesn't work, right? Now, there are other things you can do to, I was going to talk as if some of you have never been to an audiologist. I'm going to have to change my tone a little bit, but it's very important if you're going back to an audiologist, or if you're going back because you don't, to get a second opinion, that you really self-evaluate. When do you really do well? Do you always do well with one person in terms of understanding when you're in a quiet room with good lighting and no other noise? You need to know that. Or do you always do well with your phone? Or do you have trouble? So evaluate yourself so that you can say, these are the spaces I think I can get along with well, and these are the ones I have trouble with. When I'm in a meeting, I have trouble when everybody talks at once, etc. Or when the TV is too soft. So self-evaluation is very valuable so that the audiologist can integrate that information into the knowledge they have of how your auditory system is functioning that day. Okay. The other thing is to manage your acoustic environments. And this is true whether you wear hearing aids or not. This is a lovely room to speak in for two reasons. One, it has a microphone system and amplification system. My hearing aid does the very same thing this system does. Isn't that amazing? It takes the sound, it modifies it, and it puts it back in my ear, just like this microphone and an amplification system does. And when you're in a noisy restaurant, there are some things that all of you probably learned to do. Find a quiet corner, ask for the music to be turned down, put your back to the wall so there's not a lot of sound coming from behind you. You're probably able to do some of these things, and if I'm redundant, it's just because that's what I'm prepared to talk about. Good lighting is important, and some people call it lip reading. I've never used that term because for me it's just general visual information, body language and facial expression, whatever. But then there are some behavioral changes that are really important and not easy. Simple, but not easy, just like losing weight, right? If you're living with another human being in a home that has more than one room, you're usually not able to understand very well from another room. And so you have to have a discussion with everybody. Okay, these are my limitations and these are my strengths. get my attention before you talk to me. Please, just call my name. And if I don't respond, you'll know that I didn't even know you called me. If I do respond because I know you called me, but I know it's too far away, let me tell you to come closer or I'll move closer. But be in charge of the communication rules if you can. I once was counseling a couple, he had the hearing aid on for the first time, and he was there with his wife, and I was going through some of these recommendations about communicating in a house, and which involved her. And finally she said, "Why do I have to do all this stuff? He's got the problem." And that's true. Why? Well, and so I had to talk about, well, it's a mutual situation here, and you have to make some compromises on both sides. Hearing loss just doesn't affect the person with hearing loss. It affects everybody around them, as you all know. And then explore the marvelous field of technology. When I started out with hearing aid as an audiologist, it was, in the dark ages, before there was computers, before there were internet, before there was anything except a telephone and a hearing aid, that all it did was, well, it did more than just make things louder. We could take a screwdriver and make some changes in it so that we could emphasize higher pitches and so forth. But it was pretty limited. And now it's unbelievable technology, not just with hearing aids, but with remote microphones, with smart apps that can transcribe what another person is saying so that you can read it right in front of you on your phone, and many, many more. And the audiologists are usually very, very knowledgeable about that. The one thing I want to talk about that Sarah and I were talking about earlier is I want to talk about physicians. I had lunch with a physician recently, a retired physician, and we were talking about the communication issues. And he said, I never had 1 hour of lecture during my training. Now, he's in his 70s, about hearing loss, not one. And most doctors, don't. They're concerned about disease and cures and medications and surgery. So don't be surprised if a doctor says, well, you don't have any trouble. And he said, well, my wife tells me I do all the time. That's because in the doctor's office, it's a small room, it's quiet, the lighting is good, the subject matter is known, and you are usually familiar with each other. I have a moderate hearing loss. My physician is a woman. I can take my hearing aids off and have no trouble understanding her in that situation. So if she weren't, I've taught her well, if she weren't aware of the fact that you could have a significant hearing loss and still do well in the doctor's office, she wouldn't, if I had complained, she'd say, well, you don't have any trouble. So the medical community is not terribly knowledgeable about the effects of communication interference, about the effects of hearing loss, about the incidence of hearing loss. And so be advocates for other people in clarifying that. That's really, really helpful. And if you want to train your physician, please attempt to do so. That may be not on your list of things to talk with, but do it. It will be helpful. And verbal, there's a phrase that says, well, you can finish it for me. A picture is worth 1,000 words. But anytime you're watching TV, mute it and see if you can figure out what's going on. Verbal communication is extremely important for creating good relationships, and we need to maximize it as best we can. So let words be heard. And now I'll give you Dr. Sarah, my audiologist. Thank you. Takes me a while.
All right, thanks, Ann. Thanks for having me, everyone. I'm Sarah Binfet, as Bryce said, I'm the owner of SoundGate Hearing, so I know Ann well, and she invited me to come today, so I appreciate it, and thanks for having me. So I'm going to talk a little bit about, as I heard someone say, some depressing things, right? But good news is, you know, we have lots that we can do to mitigate that. And then there's often lots of questions about hearing aids, so I'll cover that a little bit, but we can always do that at the end with questions, okay? So, this is me, that's my family. So 3 kids, we live in Chanhassen, we're in the Minnetonka School District, so just a gratuitous family shot. So I first just want to talk about some of the things that you will hear a lot about with hearing loss and how it relates to the person. I think what happens a lot with how medicine works these days is people are treated as a specific area. They go to someone for very specific things as opposed to one person treating them as a whole, which used to be more what medicine was like. And hearing loss affects many parts of the body and the brain. So one of the biggest things we've learned in the last 15 years is the impact of hearing loss on cognitive decline. So hearing loss is very common, affects 1 in 3 people to some extent, whether that's mild or severe, over the age of 65. And, you know, what happens is when you aren't hearing normally, like Ann described very well, if it's quiet, if it's one-on-one, if it's good acoustics, good communication, it's not difficult to hear, even with hearing loss. But as soon as you get into a more complex environment, your brain now has to work much harder to hear. And so we call that an increased cognitive load. Your brain is having to work harder, strain, use all kinds of compensatory actions to process that incomplete auditory signal that your brain is getting. And so in order to do that, you're taking uses of the other parts of the brain away and putting it all into working hard to hear in noise. The more that goes on, the longer the brain has to do that, it gets harder and harder, and you start to lose some of those cognitive resources that were allocated for other parts of the brain. Social isolation. So I see this often as patients get older and as their hearing loss gets worse, they tend to not go into situations where they struggle to hear because they don't enjoy it. It's just too hard. And so lack of socializing, lack of communication, face-to-face, physical touch, you know, all of that also leads to that faster cognitive decline. And then brain shrinkage, which is unfortunately just a natural part of aging, that as that shrinks, we do lose information in the memory and the processing of the brain. So that's the terms, you know, you might hear MCI, which is mild cognitive impairment. Memory, attention, and problem solving are all linked to that. And this was a big Johns Hopkins study, and there have been several follow-up studies as well. So hearing loss overall is linked to a 50% higher risk of dementia, cognitive decline. So a similar study, it was called the ACHIEVE study, and you see the 2 sides of the the brain, the one with more shrinkage and then the healthy brain. The side of the left is the brain that had to have more strain over time to hear, and the side on the right is, excuse me, a healthy brain. So what we do know is that using hearing aids can slow this cognitive decline, because the hearing aids then are doing the effort for you. Your brain is not having to constantly work as hard to hear, which we want to avoid. We don't want that brain constantly working hard to hear. So there are some well-known causes that increase risk of cognitive decline or dementia. The two highest are hearing loss and high cholesterol. Depression, traumatic brain injury, diabetes, smoking, high blood pressure, alcohol use, all of those things can contribute, but the two most modifiable are hearing loss and lowering cholesterol. So we strongly emphasize early intervention, including hearing aids and social engagement, as ways to reduce this risk. This is my public service announcement, is anyone you know that is getting assessed for changes to their cognition, a memory test, a test for cognitive decline, they should absolutely have a hearing test. And that is not something that physicians are currently doing. A few do, but it is absolutely, they are so integrated that no matter the age of the person, if they're going through something like that, they should absolutely have a hearing evaluation. The sooner we identify and treat hearing loss, the less consequences there are to brain health. Hearing loss and depression, well known for decades, but I think it's more startling than you realize is that people with hearing loss are twice as likely to suffer from depression. It's, correlated with that social isolation, frustration that they can't communicate. They have to work so hard to communicate that eventually they just give up, right? And so, good news is hearing aids, we can improve that psychological and emotional changes and offset that depression and cognitive decline associated with hearing loss. Tinnitus, both ways are correct. Anyone frustrated with that, or you know someone that has it? Yeah, it's extremely common. 70 to 80% of people that have hearing loss have tinnitus. So they are separate diagnoses, but they are almost always correlated. And tinnitus can be very frustrating for providers and patients because there is really very little we know about it or how to make it just go away, right? And so it can come from cochlear damage, which is just hearing loss. It can, the way I think it's best described is the sound you hear in your head is an overactivity of the brain. So the brain is trying to make the ear work like it did when it was healthy, and that ear isn't responding. And so your brain starts to send signal after signal after signal. And that's actually what you hear, is an overactivity of the brain. There are other things like noise exposure, blood flow, viruses, medications that all can make the tinnitus more complex. But the takeaway is that often when patients start wearing amplification or hearing aids, they will notice a reduction in that tinnitus, because we're fulfilling those brain responses that it doesn't have to create such a signal and keep sending it over and over. Hearing loss and balance. So hearing loss increases fall risk, and that is predominantly because our brain, we use spatial cues to situate ourselves in our area, and how that sound is bouncing off or where that sound is coming from. When you have hearing loss, that is simply just not working how it's supposed to. And so we have a harder time identifying, where a sound is coming from, which increases our risk of falling. And as the hearing loss gets more severe, the risk of falls goes up. Hearing loss and diabetes, so this I see in the office a lot, is patients with diabetes are twice as common to have hearing loss. And that is mostly related to the vascular changes from diabetes that affect the cochlea. So poor blood flow to the ear. The ear is a highly vascular organ, lots of blood flow feeding it. And so those constant changes to that blood flow have a negative impact on hearing. Chronic inflammation, nerve damage from blood sugars being too high, and then a higher risk. So people with diabetes are more predisposed to have hearing loss. So, takeaways to how we can keep our brain and our ears healthy is get a hearing test annually, use hearing aids when they're recommended, stay socially engaged, protect your ears from noise, eat a brain-healthy diet, and manage blood sugar. Okay, so now I'll talk a little bit about hearing and hearing aids. So I agree with Ann. Where should you get a hearing test? You should find an audiologist. So there are two subsets that can provide a hearing test: an audiologist, or there is a position called a hearing instrument dispenser. So an audiologist has a graduate degree, and a dispenser has a state certificate. So an audiologist is just going to perform a more thorough evaluation. We have a broader, deeper expertise in hearing science and related health conditions. So I think it's much more of a whole patient view versus, what does your hearing look like on a chart? We provide medical level assessment, not just a sales-focused evaluation. And audiologists are better equipped to catch serious issues early. I recently had this happen. My uncle came in with some very odd symptoms. He would run his blender and he would get nauseous and would have vertigo from the loud sound. And his hearing loss was, both ears were the same. I didn't see anything that was really odd from that aspect, but this is a very odd symptom. So I referred him to a ENT that I work closely with, and he had a large growth in his brain. So, there are lots of things that we see that will cause us to refer to usually an ear, nose, and throat physician. And so I feel like if he had not been in my office, that potentially wouldn't have happened as quickly. What should happen at a hearing test? So a detailed case history, including hearing health and lifestyle. I think it's really important to get to know who is sitting in front of you, because that dictates what they are going to need as far as hearing aids and support go. So a test really should be performed in a sound booth, both tones and speech understanding. So tones simply really is a pretty basic test. It just gives us information on how softly can you hear things. For me, the more critical information is how patients do with speech understanding. And there's a few tests that we do, from simple to much more complex, and that is extremely helpful for identifying what that patient is going to need to be successful. So this is a little information than what Ann said, but I absolutely think that health insurance should be checked. to see if a patient has a hearing aid benefit and give them that information. An audiologist will bill your insurance for a hearing evaluation. If you see a hearing instrument dispenser, they will often say, the hearing exam is free. That is because they simply are not allowed to bill insurance. So Medicare covers a hearing test annually, so it's a pretty easy starting place. And then patients should absolutely be educated on their hearing loss and what it looks like and what it means to them for communication and how we can move forward. Outcomes and expectations should be discussed, and then what are the next steps? So a little bit similar to what Ann talked about, considerations when someone is thinking about hearing aids. What hearing aids are best? That absolutely is not an answer that fits every single patient. I am an independent clinic, which means I'm not owned by a hearing aid company. So I work with all the major brands. And so I think that is really critical, is if you're finding someone to work with, make sure that they are familiar with more than just one brand of hearing aid. Hearing aids are not one size fits all. There should be multiple options offered to best fit patients' needs. You should absolutely have the opportunity to demo a hearing aid, whether it's in the clinic or taking the hearing aid home for a week to see what it's like. An audiologist should offer a wide range of pricing, even pricing that compares to Costco. So if you want to you get hearing aids at that price point, you should be able to get that at a clinic that is then going to fit them properly and then give you the support that you need. So the advantage, you get better precision and long-term outcomes, and less pressure and more patient-centered care. I wish my hearing aids worked better. I hear this a lot. I often see patients after they have been to several other clinics, after they've been to Costco, after they got something off the internet, and they come to see me, and they are frustrated, their families are frustrated, I want to hear better. And so there are many reasons why this might not be working for a particular patient, even a patient that was coming in with hearing aids that were from a different audiologist. So hearing and speech understanding are not the same thing. So I always hear this phrase in my office: I can hear, but I can't understand. And that changes depending on really how well that brain is functioning. So I can have two patients with the same diagnosed hearing loss, the exact same hearing loss. And one of them, they could be successful in almost any hearing aid because cognitively their brain is functioning normally. They just need that speech information. And I can have someone with cognitive decline or other neurodivergent issues like ADHD, dyslexia, all kinds of things, autism, where their brain needs more support, and they will fall apart in noise. And so that, when Ann said people ask what brand is best, it depends on the person and what their needs are to make them the most successful. So I will often see just an improper fitting of hearing aids, whether that's the physical fit or how they're programmed. I will sometimes see, patient error, right? They're not using them properly, or it's just too complicated for them to be successful. I often see unrealistic expectations. of both the patient and or their family members, where the family will say, you know, my wife got hearing aids, but she still can't hear me from another room. That is not going to happen. And so having a conversation about what is realistic to improve communication. I think communicating in the home is, we do that much more casually than we do out in public where we're face to face. And so often that the most difficulty does happen in the home when the family's around and you're walking out, your head's in the refrigerator, and you're trying to communicate. So some of Anne's tips on proper communication can be really helpful for people. It absolutely depends on the degree or the severity of their hearing loss and how well they do with some of those speech tests. And then hearing and understanding with an aging brain. It is simply just harder. Hearing in noise is hard because background sounds mask important speech frequencies, and the brain must work harder to filter and separate speech from noise, which is especially challenging with age, hearing loss, or cognitive factors, or all of the above. Okay. Questions?
Thank you. I have a number of questions. So I don't think I have hearing loss yet. Okay.
That's better.
I don't think I have hearing loss yet, but I want to be healthy about, so if I have a hearing, I haven't had a hearing test. I don't remember when I've had a hearing test, so it's clearly I should do that probably.
Yes, yeah.
And then how frequently should I do that? And then another question, I do notice, I don't know if it's the conditions or if I do have hearing loss, but I row in the river, there's with a coach, with other teammates, depending on where I am in the boat, there's the motor from the launch is running, there's, water sounds. So sometimes I do not hear.
Yeah.
But I'm on the water. There's potential of getting wet.
Sure.
Do I even have an option of wearing a hearing aid in that situation? Anyway, I'll let someone else ask questions.
So absolutely get a baseline hearing test. Often when patients come in, they're like, I don't think I've had a test since I was, in school, in grade school. So a baseline test is a good place to start. Depending on the results, I might say you should come in once a year. I might say I'll see you in 2 or 3 years, unless something changes. So that answers that question. Also, once we get your information, then I can say, the issues you're having in that particular situation on the boat with the motor running outside, speech behind you, may just be a very normal situation that is difficult to hear in for anyone. Hearing aids are you can pretty much call them waterproof these days. So I always say I want hearing aids to work for you so you can use them as often as you need them without having to worry, oh, I better take these out. So getting them wet, rain coming on them is not going to damage them. The most concerning thing would be if you fell in and they fell off. So that would be the concern of loss, but yeah. Hopefully they fit beautifully, because I want that to happen, and you don't have to worry about that. Yeah.
I have an observation. At the moment, I'm the only male in the room. There's about 15 ladies. Could you say something about that?
Well, they may all be here for someone else.
Men just don't want to admit they have a need because we all have over age 60, that percentage. I don't know.
Yeah, I mean, I don't think that in my practice I have more women or men. I think it's pretty equal. Yeah.
So I wear hearing aids. My neighbor and her husband, friend, also both wear hearing aids. And all of us are told, wear them all the time, which I do. And this friend of mine said that her husband, he's a big reader, spends a lot of his day reading by himself in a quiet room. And he says to her, and she said to me, that he feels like he doesn't need to wear his hearing aids when there is no sound around. But his audiologist says he needs to wear them all the time. So he likes to save the battery. I think he's a little frugal.
Okay.
So I don't know. How do you argue with that, there's no sound to hear?
Yes. I mean, to some extent, it can depend on the amount of hearing loss he has. And so if it's a real mild degree of hearing loss, you have a little bit more flexibility with that. But if it's more, moderate to severe, we want them to be in several hours a day, even if it's quiet, because there are things happening around you that we want that ear to hear and then stimulate the brain. That's what we want. We want that neural activity back and forth, whether it's turning the pages on his book. If he doesn't have the hearing aids in, he's not hearing that. The light switch, his wife coming up behind him, he's unaware of his surroundings, which is detrimental in the long run. So sometimes for patients like that, you say, no, you just have to put them in the morning and take them out at night.
I'll tell her to tell him.
Yeah. The other thing that happens when patients do that is they don't get used to them. And so he doesn't wear them for 2 days, and then he puts them in at day 3, and they're going to church, and it's noisy, and he says, oh, these are noisy, I don't like how they sound, and it's because his brain has not been getting that amplified input for 72 hours. It changes very quick. Your brain quickly goes back to your hearing loss being your norm if you're not using the hearing aids consistently.
I wanted to correct myself about insurance. What I meant to say before was, if the only interest in the person you're seeing is whether you can afford their hearing aids, that's not the best solution. And they usually, obviously, some hearing aids, some insurance companies cover hearing aids, some don't. Some cover evaluations from certain providers, some don't, so it's important. The other thing I wanted to mention is fatigue. In my experience, very few people recognize the fact how hard they have to work to listen all the time, even with appropriate amplification. And it came to mind one day when I had followed a teenager who was really doing straight A student. You'd think everything was kosher. And she was going to college, and the mother asked me to write a support letter so that she didn't have to take a heavy load. And I talked about fatigue, that she wouldn't be able to work 20 hours a week as well as going to school, or whatever I said, I don't remember. And the mother said to me, that never occurred to me. Every time she came home from school, she always took a nap, but I thought that was just teenage behavior. But we do work hard at listening, and it is exhausting. And if you go to a lecture, you have to work harder. I'm well habilitated, but it is tiring, and after a while, I find myself tuning out. And you need to recognize that so that you measure the times you put yourself in difficult listening situations. Okay.
You mentioned a situation where where you said their ears were equal, and so that was all fine. My ears are not equal. I hear much better with my right than with my left, which has difficulty getting consonants. And so I find myself in situations where I'm just pulling my left hearing aid out of my ear to try to understand what somebody's saying, because it muddles it. I also find that double miking drives me crazy sometimes. When there's a microphone out there and a microphone in here,
Yep.
and it all gets so intense
Yep.
that it's very difficult, and especially in it compounds it when it's in a live space.
Yes.
The sanctuary here, I sit down front as much as I can because there's a lot of live sound coming from the mic on the pulpit, particular timbre voices and things like that come in through that double miking and the live sound that can be difficult. And I don't know whether my hearing aids are capable of adjusting for that. You know, I play around with the app.
Yep.
Or I just have to live with it. My doctor said if my left ear were worse, cochlear implant might be a solution. But that scares me to death.
Yeah, I mean, that's clearly you've got a complex history. It's a little tricky to answer without really knowing what that left ear is capable of. It sounds like it certainly, there is, when we talk about speech understanding, there is a difference between loudness and clarity. And I'm sure everyone has experienced a speaker that has gone bad, you know, where it's starting to, you know, at the ends of sounds. Sometimes patients will have what I call a bad speaker. And it doesn't matter how loud we get the sound or how, you know, perfectly programmed the hearing aid is, the speaker itself is not working properly. And so that is often what I'm talking about with patients when we talk about what's the best option for you, what's a realistic expectation, what do we need to mitigate or improve on? You know, is it a cochlear implant? Is it 2 hearing aids? Is it a crossover device? There are lots of options in a complex situation like that, which sometimes takes some trial and error. You know, let's start here, let's try this, let's go here. And so it's just, it depends on the situation and, you know, the ear itself. What are we starting with? In the last 3 months, there have been some huge improvements in hearing aid technology. You know, every couple years there is, you know, your phones, your TVs, everything. There's always newer, better, faster. But as an audiologist, it's important for me to know at what point is it worthwhile to each patient to consider something different.
We had one final question here, and then maybe you have a comment at the
Okay.
I just have a quick question about the role of lip. Oh, yeah. I have a question about the role of lip reading in the hearing. I find that if I'm even like watching somebody on TV and I can see them talk, it's more easy to understand when you hear if the TV is not synced right and it's a little bit off.
Yep.
It's like it really affects how much I understand. Do you find that to be a factor in hearing loss?
Yes, however, everyone, normal hearing as well, uses visual cues to make sense of what's being said, and like Ann said, body language and facial expressions. But absolutely, the combination of the hearing and the visual cues makes it easier. Now, if you do have hearing loss, it does help even more, or you're relying on it more.
And did you have a final comment?
I forgot to say before, Plymouth has a great system in the sanctuary, a loop system that creates a field within which you can relate directly to the microphone. Find out from your audiologist whether your amplification systems are compatible. Is that Bluetooth or FM magnetic?
No, well, do you have is it a T-coil? It's a loop? You'd have to have a T-coil program in your hearing aids. Or sometimes they have it around the neck in the device.
And we also have, for non-hearing aid users, we also have independent amplifiers that you can take into the building, into the sanctuary, and they will serve you very well. So, thank you.
Well, let me just mention before we say goodbye here, next Sunday is Mental Health Sunday, and our presenter will be Siri Stroman. She's pastor at Atonement Lutheran in Bloomington, and she's going to speak on religious trauma, how it manifests and from where it comes, and she will also suggest ways to address deep spiritual wounds. Should be fascinating. But let's give a hand to Sarah and Thank you.
Thank you.
Sure, Sarah will be around a little while if you want to talk afterwards.
Yes, absolutely. Yep. Yeah.